All right, thanks everybody, and we'll go ahead and get started. I'm Dreama Gentry. Thanks for joining today for this conversation for action. I want to start by apologizing for last month. We had technical difficulties last month and we're not able to get anybody on. So I apologize for that. Russ Orwell, who was our speaker, is going to join us next month. So at the end today, I'll have a slide and he'll be joining us talking about dual enrollment and mentoring and other high impact practices. So don't know what happened, but we keep moving forward. Glad that we're here with you today. And joining me today is Dr. Ginny Sprang and Dr. Vestena Robbins. So Jenny, Tina, thank you for joining me. The conversation today is around the stressors, the trauma impacted by our students and the communities, and how we can actually address that and what we can be thinking about so that we can meet the students where they are. So Jenny, I'll start with you. Just sort of introduce yourself and your work.
So I'm Ginny Sprang. I'm a professor at the University of Kentucky in the Department of Psychiatry, and I run the UK Center on Trauma in Children. And I think, one of the things that my center probably is most proud of is just our real kind of laser focus on trauma and trauma-informed care and how to help systems and organizations be more trauma-informed. So that's kind of the perspective I'm coming from today.
Yeah, and I appreciate you joining us. And I know through the years, as I've done this work here and people across the nation have done the work, your center is one that really guides that national conversation. So I really appreciate you joining us. We also have joining us Dr. Vistina Robbins. And Tina, we were in college together, so it's great to be here with you today. So talk about your work and your role.
So good morning, everybody. And let me start by saying that it is an incredible pleasure to be here with you and to share this space with one of my favorite people, Dreama. My name is Tina Robbins, and I am a senior executive advisor for the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. So that's a mouthful. So we call ourselves DBHDID for short, because, that's easy to say too, right? But what I do in the department is I focus on innovations and implementation support. So my commissioner often refers to me as a starter, like the starter that you use for, a pie or something like that, because I get things, I plan something, I get things launched, and then I turn it over to someone else and support them in the implementation efforts. And so that's really much of what I did a few years ago with our trauma-informed care efforts. I was working with her to start this initiative, and now we have turned it over to some other very incredibly skilled and knowledgeable folks. And so I'm excited to be able to bring the perspective today of some of the very specific kinds of strategies that Kentucky has engaged in.
Yeah, and I think when we were thinking about this, it's important that we know the research, we know the larger frame, but then for us to learn and think about how one state and one location then has engaged. So that's the frame we're hoping to give today. So I'm excited, and we'll just jump right in, right, to the questions. So Jenny, I'll start with you. We know that students face many, many stressors, and those stressors have become even more pronounced with these simultaneous, we've got a global pandemic, we have racial injustice, persistent poverty, we have a substance use epidemic. So tell us how these stressors and trauma can impact development of a young person.
So that's a great question. And maybe I'll just start with kind of just the basic thing, and that is this adverse childhood experiences study that probably maybe most people know about, but maybe not everyone. We call it the ACEs study, but it really provided us some real important information about how stressors, including some of these that you just mentioned, can impact kind of the course of somebody's life. So before ACEs, what we knew about childhood stressors and adversities and traumas really came from just a few child maltreatment studies, and more specifically about investigations about physical or sexual abuse in isolation. So this ACEs study really gave us some good information about adversities in combination. And until that time, we knew that the risk for poor health and mental health was really high in some groups of people, but we knew that risk wasn't really evenly distributed, and there was this context and these conditions that maybe exist that made somebody more likely to have problems. So this ACEs studies and all the like adjunctive studies that have come since then have really demonstrated to us that just having an adversity in childhood is really common. In fact, if we took a poll of all the listeners of this webinar, which we will not do, we would find really high rates of exposure to childhood adversity. Some of those things are traumatic and some are just stressors, but this is true regardless of whatever group you convene. It cuts across all socioeconomic strata, but it is especially salient in individuals who grow up in impoverished communities. As you know, poverty complicates so many aspects of life. We also know that these adversities kind of work together, and there's a cumulative effect. They kind of build on one another, and that the more childhood adversity a person is exposed to, the more likely they are to develop, health risk behaviors like smoking, alcohol abuse, IV drug use, having more than 50 sexual partners. And that as these health risk behaviors increase, so does the incidence of all kinds of problems, both psychiatric and medical, and even our life expectancy changes. In fact, those people that have more than 6 or more adverse childhood experiences die 20 years earlier than those that have none. So the developmental implications here are both short and long term. We see the intermediate effects being changes in the cognitions, the way we think about things, our physiology, like trauma can change our neurobiology and the way our brain works and the level of stress hormones in our body. And it certainly can change our behavior. But when those types of changes persist for a long time, they really do impact our health and well-being. So these ACEs studies have taught us a lot about the cumulative burden of ongoing exposure to toxic stress. But that's just part of the problem. That's just a little piece of the story. We have learned from trauma research and a lot of other work with ACEs that not all ACEs are created equal. In fact, certain ACEs interact in a way, we call it synergistically, to increase the overall risk. So, for example, sexual abuse is the most synergistically reactive ACE, meaning that it contributes disproportionately to the harm that a person is experiencing. It has like an additive effect. So it's not just that 1 + 1 = 2. If sexual abuse is in the equation, that we see that the total effect is greater than the sum of its parts. So sexual abuse plus having a caregiver who uses substances, that's not just 1 + 1. In that case, 1 + 1 might not equal 2, it might equal 10. And so this is really important because this kind of additive synergy between these different types of adversities is what we call one of the most biomedically relevant phenomenons. That means it impacts all of our systems, our health, our mental health, our development, how a person learns, how they interact with the world around them, the type of parents they become. And you mentioned racial injustice, and that's often the lens that people are viewing their experiences through. So if they're, if there's racial trauma, there's community violence against people due to their race, ethnicity, or culture, that leads a person to feel unsafe in their community. And when we don't have, physical or psychological safety, that undermines everything. It undermines our success in life, our ability to be successful in college, and even in life itself. And you really can't expect somebody to recover from a traumatic event if they don't feel safe, like if the threat is still ongoing. So the bottom line is that adversities in childhood impact health and well-being for a lifetime, that certain traumatic events interact with one another to create this biopsychosocial response that really impacts development in a negative way, and context can exacerbate a person's ability to manage their trauma symptoms.
That's really helpful. And I think that it, as somebody who's worked with young people for many, many years, it resonates, right? And I love it when the science resonates with what we see in the real world. And it gives some language and some science to what we're doing. Tina, Jenny described the impact of stress and trauma on that development. Can you share some examples of how here in Kentucky groups are addressing the impact of these stressors on children and youth? Because really it's about knowing they exist and then addressing them.
Yeah, absolutely. I'm happy to do that. So first, let me say that Kentucky is extremely fortunate to have this Center on Trauma in Children led by Jenny right here in our backyard in the University of Kentucky. I say that to people all the time. But just know that this is a national center. So Jenny and her expertise are available nationwide and maybe even internationally, right, Jenny? So, but my department, which is the State Behavioral Health Authority, so we're responsible for behavioral health services and supports in the state. And many other state government and quasi-governmental agencies have maintained a partnership with the center for many years. And I sincerely believe that this partnership and the expertise of Dr. Sprang and her staff is one of the primary levers that's propelled Kentucky forward in our efforts to address the stressors that were just mentioned that are experienced by our children and youth and communities. And so as Dr. Sprang noted, toxic stress and trauma impact youth development and well-being in many different ways. And so our response to this impact has to be multifaceted. But before I share some of the specific strategies, I just want to convey the importance of viewing trauma-informed approaches as a universal approach, a population-based public health strategy. So while we know that many of our children and youth and young adults and families and communities have faced adversities, many of which Dr. Sprang talked about, and have been exposed to traumatic stressors and experiences, we need to assume that trauma is universal and adopt universal trauma responses. And so we understand that trauma and adversities, and we often refer to the ACEs. I know, Jenny, you talked about the Adverse Childhood Experiences study. We also have taken a look at some of the work of Wendy Ellis with the Milken Institute at the School of Public Health at George Washington, who also includes within that adverse community environments. And so we call that the pair of ACEs. And we know those are very common in the folks that we serve. And so we feel like we should approach all individuals and families as if trauma is possible. So a universal sort of perspective on that. So I just wanted to give that context before we jump into some of the strategies. And so here in Kentucky, we've engaged in several different strategies. And I'm just going to pick a few that I selected. But in terms of focusing really on the general population, we've done a lot of education and awareness of trauma and its impact. We've done a lot of education around the Adverse Childhood Experiences study and those adverse community environments. We've established within my department a multidisciplinary trauma-informed care steering committee. So these are folks from a variety of areas and disciplines that convene together. I believe Dr. Sprang is on that steering committee as well, but it really drives the work around trauma-informed care in the state. Within my own cabinet, and my cabinet is the Cabinet for Health and Family Services, we house Medicaid, behavioral health, child welfare, public health. So we have a lot of the human services and health related entities within our cabinet. We have established a resilience roundtable. And so that is really a way for us to coordinate across our different departments and agencies within the cabinet around trauma mitigation strategies and resilience building strategies. And so we have that kind of a structure there. We've had presentations on ACEs from our Senior Deputy Commissioner in Public Health, who's part of in ACEs and trauma have been included as part of our state public health plan. And that's really, I think, kind of unique that public health is now adopting and thinking about that. It's not just in the realm of behavioral health anymore that we're paying attention to this. So we're doing a lot of things just to promote education and awareness. We also have targeted professional development that's happening pretty extensively across the state, again, with not just behavioral health folks, but with educators, with our court folks, with juvenile justice workers, with anybody and everybody, after school programming, anybody and everybody who touches our youth and families. And we're doing that through various learning collaboratives. So that's another sort of mechanism that we're using. In the early intervention space, some specific things that we're doing, youth mental health first aid training, and I'll follow this up with resources for you all so that you don't have to write all of this down now, but I'll follow up so that you can learn more about youth mental health first aid. We're using various funding sources to build capacity within our state so that folks are able to go out and deliver youth mental health first aid training. Psychological first aid, we just received disaster behavioral health response grant funds that is allowing us to equip folks in the community with psychological first aid. So again, another evidence-based early intervention approach that you can learn more about. Also, trauma-informed treatment approaches. We have trauma-focused cognitive behavioral therapy. Remember, Jenny talked about how trauma impacts cognition and therefore behavior. And so trauma-focused CBT is an approach that clinically trained staff can use to address trauma. We also have a couple of interventions, again, under the leadership of Jenny and other experts in this area, where we're training some of our folks to deliver a couple of very specific types of treatment interventions that can be done in school settings. So we have cognitive behavioral interventions in schools, or CBITs for short, or we also use something called Target, Trauma Affect Regulation Guide for Education and Therapy. And so those are a couple of interventions that we're rolling out currently in the state, again, that can be delivered within a school setting. We're also paying attention now, and I wish we had done this long before now, but we're doing it now, to racial trauma. And Jenny mentioned that as well. So we are working very closely with Dr. Stephen Nifley at Spalding University, who is one of the very few, I believe, experts in the nation on racial trauma therapy. And in fact, he has one of the very few centers in the nation, clinics in the nation, that delivers racial trauma therapy and trains folks in racial trauma therapy. And in fact, we are working with him and funding him to adapt his racial trauma therapy for children 13 and younger. So right now it's only been shown to be effective for 13 years and older, but we're funding him to be able to adapt that approach so that it can be used with children younger than 13. So again, that whole lifespan perspective that we're talking about. And then finally, and Ginny may talk about this a little bit more because this is something she is leading, but we have also focused very heavily on our educators and making sure that our educators and our school personnel understand trauma and understand how to respond to that. And so we have trauma-informed practices for educators, learning collaboratives that are operating on a regular and ongoing basis. So those are the treatment approaches. And then you get to more of the policy piece. And I'll just very quickly mention that we have passed legislation in 2019 called the School Safety and Resilience Act. And that followed on the heels of a shooting in Kentucky, a school shooting in Kentucky. That is, I feel like, one of the most comprehensive pieces of legislation around school safety that I'm aware of. And I think they did an incredible job of balancing physical safety, what we call the hardware in schools, with the psychological safety, which we refer to as the heartware, right? So there are things in this legislation, and I'll send you the link so that you can look at it, but districts have to have trauma-informed education plans. Those were due this past July. We've created, in partnership with the Kentucky Department of Education, a trauma-informed toolkit that will guide schools in understanding trauma and traumatic stress. What does it look like to be a trauma-informed school? How do you carry out a trauma-informed active shooter drill? Wow, there's a lot being discussed around those kinds of things now. How do you do a lockdown drill and practice those in ways that don't traumatize your students and your teachers for that matter? And then we also, in that legislation, another piece that's really a nice trauma-informed piece is we've adopted the Handle with Care notification system. And if you don't know about Handle with Care, I encourage you to check it out. You can Google it. But essentially, it's a notification system where schools and districts collaborate with law enforcement. And if law enforcement is on the scene of a situation where there's a student and potential trauma occurred, let's say there was a domestic violence dispute or something of that nature, they have a way to alert that child's school so that that school becomes aware that that child potentially experienced a traumatic event the night before, and they can be prepared to address that. So again, I encourage you to take a look at that legislation. So as you'll see, we have things happening at education and awareness, at the treatment and intervention level with school personnel and with behavioral health providers and others. And then we also have some policy levers that we've engaged in, and all of those things working together at multiple levels. So happy to give any more information about any of those. I know I went through that quickly, but happy to provide any resources that folks may want.
And I think it'll be helpful to, if you'll send us like a resource sheet, we'll post it when we post this webinar. Because we do know that today is actually the first day of school in many states, and we're doing this webinar on the first day of school. So I do think that people will be watching this later, and that resource guide will be really important. And I appreciate the framing, Tina, around the universal strategies, but then also recognizing things that like handle with care, right? That really, when a young person does have that piece, that trauma, we know about it, right? And I think that's, as college access and success professionals, we're working to ensure that our school has a system in place to serve all students, but then how do we interact and work with individual kids? So that's really, really helpful. And thinking about the practitioners, the folks that are there every day working with young people, helping them with their college access and success planning, getting to know them. They're really on that front line. Jenny, we talked about the impact of trauma on kids and youth, but I've heard people talk about secondary traumatic stress. And I'm wondering, can you share a little bit about that? Because I think a lot about the folks that are working every day with young people and wonder how that's impacting them.
Sure. So, we have a pretty good literature base, a lot of studies now that are documenting that professionals that are working with youth and young adults that have been exposed to trauma can also experience traumatic stress symptoms due to indirect exposure to trauma material. So what does that mean really? What do I mean by that? That could be like repeatedly hearing the graphic details of another person's trauma, or having to repeat these details to other professionals. So if you're, a college access and success person, and you're, hearing about somebody tells you a story about something traumatic that happened to them, and you think, somebody else needs to be involved in this, then having to repeat that. And some people have this kind of repeated chronic task of making referrals, getting people connected, accessing resources, or even getting supervision about that. It could be like having to testify in court. If you get involved with someone who has a court-involved traumatic event, and just seeing the wake of trauma's destruction on a child. This could be self-mutilation, suicidal gestures or attempts, hoarding food, very extreme regulation, And so we see some of our young adults at the college age, still grappling with some of these issues that are really born out of child maltreatment or childhood trauma. And this is what we call secondary traumatic stress. Some people are surprised that you can get these trauma symptoms from this kind of indirect exposure. But even the DSM-5 has added indirect exposure as a criterion A in defining what constitutes a traumatic event. When you're thinking about PTSD, it says something like repeated and extreme exposure to adverse details during the course of your professional duties. And so what we have learned, from our own work is about between 15 and 20% of professionals are going to develop the most extreme form of secondary traumatic stress, which is PTSD. It's just PTSD. But the majority of people kind of fall in the middle. They are about 65% are reporting that they have some symptoms of traumatic stress, but it doesn't impact their functioning. They're still able to work and they're doing okay in their families and socially they're interacting well. Or maybe their symptoms are severe enough that it is impacting family functioning and their work, but it's not enough to call it PTSD. This is where the majority of the workforce is falling. And, these symptoms tend to fall into the domains of what we call intrusive symptoms or arousal and reactivity symptoms. So like thinking about the client's trauma, intrusive memories is the number one symptom of secondary traumatic stress that professionals usually endorse. So we're just thinking about that story that kid told me, I can't get it out of my mind. It's waking me up at night and it's causing me to be really irritable and frustrated and maybe even changing my expectations of the world. I'm starting to get a little cynical and hardened because of it. So, as these college access and success practitioners, are in a position to hear stories and see the aftermath of trauma, you may see this and you may feel and experience some of these symptoms, and that would be absolutely normal. In fact, we call this a normal expected occupational hazard of working with populations that have trauma experiences. It's not that your coping's not good enough. It's not that you're, not professional enough or strong enough. It just happens. It happens to all of us. It's happened to me. It's happened to most anybody who works with this population. So we really want to pay attention to it. And I did want to mention that there are some self-screening tools that people can use that we really think it's important that they're using them privately and confidentially. We don't want organizations to be like passing out a measure and having people report their symptoms, to a boss or a supervisor. We want people to have the information about how they're doing and be linked to resources. So I'm going to give you some information about how to do that. If you don't have any symptoms, and there are a lot of people that maybe right now at this point in your career, you say, that's really not an issue for me. That's great. But it's also important, I think, that you take some preventative strategies to build your resiliency so you can keep doing this work and you're ready for some of those more toxic exposures when they occur. So I'm going to post a link in the chat that people can use to access some of these tools privately and confidentially. And if your score, so you take the measure, and if your score, based on your score, you will get resources that are really tailored to your score. So if your scores are low, you might get a lot of psychoeducational material. If your scores are really high, there's also a link to providers throughout the state that do this kind of work that you can access, plus lots of tools and other things that you can use to address this in your own work and share with other people around you. So I'm going to post that link just right now.
Yeah, and I appreciate you doing that because I do think that, this work is hard work and we have to ensure that the folks doing it every day are taking care of themselves, right? So Tina, thinking about this, what has Kentucky done to address, if they do, or what can we do if we're leading organizations do to address this among those folks that are on the front lines working with kids and children?
Yeah, great question. So I want to share what I think is one of my biggest aha moments in this work. So remember, I mentioned that my commissioner and I had started talking about how to move our organization toward becoming more trauma informed. I mean, we're the state behavioral health authority, right? Who better to become trauma informed? And so, but one of my biggest aha moments actually happened at a secondary traumatic stress convening that again, Jenny, her group was hosting, and somebody at that convening said, your organization can't be trauma informed unless it's secondary traumatic stress informed first. And we both went, wow, gosh, why did we not think about that? I mean, and it's so true. And that statement had such a critical impact on us as we were considering how best to address the impact of trauma within those we serve. And so, we started down a path after that of not just focusing on that being trauma informed in terms of those that we serve, but also taking a look at our workforce. And so it just truly changed our perspective on that. And so we've worked, again, very closely with Jenny and her group and some other folks through their secondary traumatic stress innovations and solutions center. And Jenny may talk a little bit more about that, but it's really around developing and testing workforce development and protection interventions. And so here in Kentucky, we recognize the importance of that even before the onset of COVID. Now, I think probably a lot of states started really paying attention to that post-COVID or during COVID, but we were starting to recognize that prior to COVID. But we recognize that, any professional who works directly with children and youth that are exposed to trauma, and as Jenny said, hears them recount their traumatic experiences, is at risk of secondary traumatic stress or other related conditions. And so, many state agencies and other organizations in Kentucky have partnered with the center and other STS, secondary traumatic stress, STS experts to both prevent and mitigate the impact of secondary traumatic stress and to promote resilience. And so, again, as I said earlier, with our trauma-informed approaches, we've taken a multi-pronged approach and really started to address STS and related conditions at multiple levels. And so I'll talk about what we've done at the individual level, at the supervisory level, and then at the organizational level, so you can kind of see that leveled response. So at the individual level, many of our state agencies and organizations have offered professional development opportunities to increase knowledge and awareness among our workforce of the effects of secondary traumatic stress and related conditions. I think Jenny mentioned some of these: burnout, compassion fatigue, vicarious traumatization, compassion satisfaction, those related conditions, and really to provide guidance and support to staff to, in many cases, driving them to create and implement self-care plans. And Jenny, I think, alluded to some of this earlier. And those self-care plans really begin with more of a personal inventory of some of the warning signs. And then there's an assessment of possible self-care practices. And then the person makes a commitment to specific self-care practices across life domains, because going back to what Jenny said, it affects you physically and relationally and emotionally and spiritually and professionally. And so you really need to think about self-care from all of those different perspectives. And there are some sample self-care plans that I'm sure Jenny or I can share with folks that you can use. So at the next level, so that's kind of the individual level. At the next level, we recognize that we need to arm our supervisors, folks that are, the middle management, if you will, or the supervisors, with knowledge and skills necessary to support their direct reports. And so we've hosted specialized professional development opportunities just for supervisors. In fact, our Cabinet for Health and Family Services, which I talked about earlier, has just launched a 4-part series for supervisors on secondary traumatic stress and related conditions. And just yesterday, we had over 400 supervisors voluntarily participate in that first webinar. But that kind of participation just doesn't happen, right? I mean, it just doesn't magically happen that all 400 go, oh yeah, let's just hop right on this webinar because I don't have anything else to do. It requires leadership to ensure that the supervisors realize the importance of secondary traumatic stress and the impact that it has on their direct reports, and that they're supported in their role as secondary traumatic stress change agents. And so I truly believe supervisors are the linchpins in all of this. And so one of the things that I'll demonstrate in terms of just real leadership buy-in is that our cabinet secretary named resilience as one of the 4 pillars within our cabinet, which is huge. And secondary traumatic stress and addressing that is part of that. So workforce resilience is part of that. And so it allows staff to see that promoting resilience among both the workforce and those we serve is a priority for our organization and our cabinet at large. And so I just want to mention the next level, which is organizational. So various agencies and organizations in Kentucky have partnered again with Jenny and her group to implement secondary traumatic stress breakthrough series collaboratives. So we call those STSBSCs, and that just rolls right off the tongue. But these secondary traumatic stress breakthrough series collaboratives are these unique quality improvement and implementation collaboratives that take place over a series of months. And participating teams make changes in their organizational practices and their policies and their environment to respond to, staff trauma and to promote staff wellness. And so we have held secondary traumatic stress breakthrough series collaboratives with our community mental health center staff in the state. They serve as our public behavioral health safety net. So they see a lot of and are exposed to a lot of trauma on a day-to-day basis. We've done it with our Department for Community-Based Services, which is our child welfare and family support state agency. And we've done it with school districts through a partnership with the Kentucky Department of Ed. And again, Jenny is the expert in this and can talk more about it. But, let me just end by saying that for our work in education and human services, and for you all as college access and success folks, humans are the intervention, right? We are the intervention. And so it behooves all of us to do what we can to support our workforce. And we believe that engaging in strategies that prevent and mitigate the effects of secondary traumatic stress and those related conditions is critical to decreasing absenteeism, burnout, attrition, all of those kinds of things, but ultimately to increase the quality of care that we provide to those that we truly are privileged to serve. So.
And thinking about that, we call these conversations for action, because the folks that listen to these, that watch these, are thinking about what can I do in my school or community organization to really increase resilience in this case, right? So Jenny, if someone is doing this work and they're sitting within a school or an organization that partners with the school, what do they need to be thinking about when they're looking at of transforming their system of care into one that's trauma informed? And then Tina, I'll ask you to answer that same piece.
Yeah. I think when we talk about trauma-informed care organizations or an STS-informed care organization, we're really talking about at the organizational level, an entity that really recognizes that for people who have traumatic experiences, that this creates kind of the lens through which they view the world, and that those experiences can terrify them, overwhelm them, and that they've kind of violated their sense of what's right and wrong, changes their assumptions about the world. We often talk about it as a shattering of assumptions around safety. And benevolence, am I worthy of benevolence? Will good things happen to me? Can I expect what other people expect in the world? And so a trauma-informed care organization is really committed to restoring safety and power and self-worth. And so there's some things that we try to do when we're promoting a trauma-informed approach. And there's 6 principles that SAMHSA has talked about that I think have a lot of relevance and a lot of opportunities for action, because you can begin to address these even in small ways. If your organization as a whole has not yet taken on the challenge of becoming trauma-informed care, you can change and make your work more trauma-informed just by kind of implementing some of these principles. So the first is around safety. And I think this is core. This is core and foundational for people. They need to feel physically and psychologically safe in the work. And so people may say, well, I'm not doing anything to threaten them. But there are many ways that our systems and professionals within those systems go about doing their work that may undermine someone's sense of physical or psychological safety. So we need to really pay attention to things like respecting privacy and confidentiality. So we're not going to compromise someone or, in some ways, sabotage them by divulging things that are private or not keeping our word about privacy and confidentiality. We want to take a non-judgmental attitude because understanding from a trauma perspective that their sense of self-worth and self-efficacy has been undermined by what's happened to them. So many trauma experiences are humiliating. And think about if you're a person that grows up in a home where you're being physically or sexually abused, you're being degraded and demoralized and humiliated. And so we want to pay attention. Are there things that are happening in our workplace where we're humiliating or embarrassing our clients? And we want to make sure that we are taking actions to prevent that. We want to attend to the safety needs of the people that we're working with. So we may think everything is fine, but we rarely ask the question, do you feel safe in your home? Do you feel safe in your relationships? Do you feel safe on campus? People have a different subjective appraisal of safety based on experience. Experience changes the way we view the world. And so while we may have one interpretation, they may have a different interpretation. So that's safety is like a good place to start. The second is around trustworthiness and transparency. And, we really want to organize our work in a way where we have the goal of building and maintaining trust, not just with our clients and the family members that we might be interacting with, but with our staff and the way we treat each other. And this means being consistent, always doing what you say you're going to do. And if things change, giving a rationale for that, admitting when you're wrong, acknowledging and helping students overcome some of these psychological barriers to success that they might have. So also recognizing that people come in with different worldviews. So if you belong to a group, racial, ethnic, cultural group that has experienced historical trauma, which means that generationally, the group as a whole has been subjected to injustices and trauma, there may be personal narratives the individual brings with them into the work. We call this invisible suitcase, an invisible suitcase insurance. It's their assumptions about themselves, others, and the world that really changes the way that they interpret what you're saying and the way that they might experience your services. So number one, being aware of the invisible suitcase, and then acting in such a way that you're counteracting any negative suitcase messages that they may be bringing with them. The third thing that I think an organization should do is really build strong peer support support networks and really facilitate self-help. So a key principle of trauma-informed care is helping people overcome that loss of control that they have and gaining their own independence. And so a key vehicle for doing that is building trust, establishing safety, and empowering people. So we know that young adults are really influenced by their peers. So building strong supportive peer networks is really important in one way to do this. And then empowering young adults who may have been disenfranchised by their race, their ethnicity, and just life experience, and can be a real launch pad for success. The fourth principle is around collaboration. And one of the biggest, most important findings from several decades of trauma research is that people can recover from trauma by having corrective emotional experiences. And it doesn't have to be a parent. It can be a coach, it could be a teacher, it could be a therapist, it could be a grandparent, it could be an uncle, it could be a neighbor. Certainly it could be a college access and success person. And what we want to do is understand that healing happens in relationship and in some meaningful sharing of power and decision making. So you don't have to be a therapist to be therapeutic. And in the way that you interact with someone, what you're showing them through your actions and your collaboration with them is that they're worthy of benevolence. And that whole act of showing someone that they're worthy of benevolence becomes kind of the foundation for resilience throughout their life. And so that's like an important piece of being trauma informed, is this like collaboration and mutuality. The fifth principle is about voice and choice. So what we want to do is build on what young adults and communities have to offer, rather than always responding to perceived deficits. So this is really a strength-based approach. And so trauma, as you know, is at its core a loss of power and control. So trauma-informed care gives control back to the person to make their own decisions. So rather than structuring things with a hierarchy, I'm the expert and you're here to receive my wisdom. You're building a more collaborative, equal relationship where you're learning from each other and you're sharing information that will help both of you be successful. You in your job and the young adult in their quest to be successful in their work. And then finally is really about cultural, historical, and gender sensitivity. So being able to look past your own cultural biases and stereotypes and offer really racially and culturally sensitive and responsive services. That by doing that, you're leveraging the healing value of some of their own traditional cultural routines, rituals, and connections. And you're acknowledging and holding space for issues around historical trauma, community violence, or even current racial trauma to kind of emerge. And because it's there and it's influencing their perception of the way they're using services and the way they trust you and feel safe. So acknowledging that so those conversations can happen and come to the forefront is a really important piece of this overall trauma-informed care approach. And then finally, I'm going to echo what Tina has said. I absolutely believe that you cannot expect professionals to deliver trauma-informed care if these same principles are not applied to them. So if they're working in a toxic environment where they have no voice and choice, where there is no collaboration or mutuality, where they don't feel physically or psychologically safe, is a tall order. And I will, maybe even posit that it would fail eventually because people can't exercise this really sensitive, responsive work if they're suffering from the same symptoms that their clients are. So that's why we're really focusing on helping organizations move towards becoming STS informed so that the workforce has the ability, the resiliency, the skill, and the experience to enact a trauma-informed approach.
I think that, as you were going through those 6 pieces, I was thinking, okay, to be really great at college access and success, you have to be doing those things in that frame too. So it makes sense, right? It's relationship, it's asset based, it's giving control to the other person, right? So some of the same things that we bake into how we help young people think about career pathways and educational pathways, those same skills can go over into this area. So that's really great. And if you will send us a link to those 6 things, or if you have a slide or something, that would be really helpful for folks listening to this. So Tina, just a question, if I'm somebody who's working in a school with a principal that is helping, and we want to get all of our kids out of our school ready for that next educational journey, and we realize this is a piece of it, where do we start, or how do we start the conversation?
So that's a great question. And I think there are lots of ways that organizations can be supported in their efforts to become trauma informed. There's not one right way. But I wanted to share today just some of the lessons learned from my perspective of what we have found helpful in my department specifically. And there are really kind of 3 tools or mechanisms or strategies that I think have been most important. And one, the first one really is adopting a framework to guide your transformation efforts. And so, Jenny mentioned and walked us through the 6 principles from SAMHSA. One of the things that our department found incredibly helpful was we adopted a framework. It's called the Trauma Informed Care Continuum from Wisconsin. And it sort of describes an organizational perspective on what an organization that's trauma aware, trauma sensitive, trauma responsive, and trauma informed. And I would like to see them add secondary trauma informed on the continuum, but it's a continuum. And it kind of helps you gauge where you are along the continuum. And it incorporates the 6 principles in there that Jenny mentioned. And so having that kind of a framework helped us as an organization to kind of gauge where we were. And so my commissioner and I, we walked into a couple of meetings and thought, oh, we're most definitely trauma informed. And then we look at this continuum and we're like, oh my, we are probably more like trauma sensitive. So it brought forth that awareness and gave us that framework. And I'm a big person, I'm a big believer in assessing situations, right? And using data to drive where you go. And that's exactly what we did. The second thing I'll talk about in terms of a mechanism that I think schools could and have probably already adopted in other realms, that's the use of learning in quality improvement collaboratives or communities of practice or professional development, whatever they may call those, professional development groups or whatever. And so we've hosted learning collaboratives related to specific trauma-informed practices, as I mentioned, for educators to promote the competency of our behavioral health workforce in specific evidence-based trauma treatments like trauma-focused CBT. We've also developed communities of practice to promote workforce resilience within our cabinet. And so those are all sort of peer-oriented learning mechanisms, if you will, and work mechanisms that I think schools and college access and success practitioners can adopt. And so think about those as mechanisms for moving your work forward and learning from your peers and bringing in expert consultation as needed. And then lastly, I would mention another huge benefit groups as a way to take our efforts to scale, right? And so we have an interagency body in Kentucky that has all the child serving agencies at the table. And we have utilized that multidisciplinary group called SEAC, State Interagency Council for Children, to really promote trauma-informed practices across different agencies, right? And so if you think about college access and success practitioners, you don't just want trauma-informed practices being conducted by those folks. You want all the folks that interact with students to be trauma-informed, right? So take advantage of educating and pushing the work forward with those interagency bodies that are already existing, and just bring that work forward to those bodies. And so that's really three kind of mechanisms that I would suggest in terms of getting the work to move forward.
And I love that, right? Be really honest about where we are as systems, as organizations, as folks are doing this work, develop that plan. And then you're right, we already use communities of practice. So using those tools. So those really make sense. So we're at the time. I wanted to talk with you all more, but we are at time, and it's been wonderful. I appreciate this. If you all will send your resources, we'll make sure those are posted along with this. I do want to remind everyone of next month's Conversation for Action. It'll be September the 8th, and there is Sam with the thing. And Russ will join us, and he'll be talking about high impact practices of dual enrollment. He just released a book over this last 6 months on dual enrollment, and then also mentoring, because he has written that he came from a Gear Up program before he started working as a professor at Merrimack. And so that's really nice. I think he will be able to speak to what we do every day. So Tina, Jenny, thank you so much for joining. And it was great being with you all. And we'll be posting this recording along with your resources. So thanks so much. And thanks everybody. I know there was a question we didn't get to. We'll get that answered. I just saw it around making sure that as we're doing this work, we're thinking about youth that have intellectual and developmental disabilities. And so we'll make sure that some of the material we post relates to that. So thank you, everybody, and enjoy the rest of your day.